itself on a self-funded basis. We've actually done a considerable amount of historical performance over the last couple of weeks to try to address some of the questions relative to the $9 million for the prescription drug plan, et cetera. So I think we've got some clarifications for you there. We've also included the regionalization piece just in very short scope. I know we have a presentation again tomorrow on that's in greater detail. This will give you just the financial components of that.
And just for clarification, tomorrow's presentation is in Health and Human Services, correct? Or Human Resources?
Human resources.
In Human Resources.
I believe so, yes.
Okay.
So in terms of, let's see. There we go. So in terms of our overall role, we're a regionally based consulting firm. We've been doing this since 2007 as Employee Benefits International. Prior to that, I was with another firm and we did the consulting here. So when you combine it, it's been about 10 plus years. We've got 31 people located here in Cuyahoga County that do the health and welfare consulting on behalf of the county. We also have an office in Phoenix, Arizona. And combined, we manage approximately $900 million in self-funded healthcare spend and fully insured healthcare spend. We are one of the fastest growing firms in Northeast Ohio. And have been recognized for that purpose. One of the things that makes us unique in terms of consulting firms is the fact that we operate in multiple states. We also operate in multiple countries. And specifically for this work, we run a government unit. So we're considered a subject matter expert in this area. We represent probably 80 or so large government entities. To give you some example in terms of scale and size, Cuyahoga County would be one of the larger ones, City of Cleveland, City of Akron, Summit County, Lake County. Some of the largest public sector entities in Northeast Ohio are clients of ours and have been for a number of years. One of the other areas that we focus on is aggregation pools. So if you look at how to piece together healthcare aggregate purchasing, on behalf of large organizations, county governments are uniquely positioned to be able to do that, as are other entities. We manage the county's regionalization program today, along with Lake counties and Summit counties here in Northeast Ohio, along with several other council of government formats. So we're very familiar with how this all works. In terms of who actually works on your account, I just want to touch on that as well. Outside of myself as the lead consultant, we've got a CPA on staff that's a former ODI auditor. He's spent 15 years in government and fund accounting, so we're very well versed in how your funds typically work. We've got a medical underwriter on staff that helps price our rates. We also house a lot of your information in terms of historical data. We're able to customize that for your needs, and that's run by our database administrator. She's versed in Access and SQL, and that's where we house all of your information. And then we've got various account managers that also touch your account for communication purposes, for enrollment purposes, things of that nature. Questions on that so far?
Thank you.
I'm not going to go through the list of entities that we deal with in terms of public sector, but it will give you some sense of the scale of what we do. I would tell you we are probably arguably the largest public sector consultant in Ohio, and that grows every day. So what do we actually do for the county? In terms of our benefit advice and recommendations, we manage the overall performance and plan aspects. So we recommend benefit changes on an annual basis, contribution changes for employees. We also provide coordination around the wellness program that you have as well. One of the main functions that we perform is the healthcare budgeting process and the rate projections. So this is to make sure that the county has enough money on an annual basis to operate this plan in a fiscally responsible manner. It's important, I think, to understand the history of it. Prior to 2010, the county handled this responsibility itself. It set its own rate structures, reported back to us. There was some concern at that time that the county was building reserves far faster than it needed. So we got involved in the process in 2010 and took over that role of actually building the funding rates that generate your budget on an annual basis.
Well, let me just stop you there. Are there any questions on that part of their responsibilities? Yes, Ms. Conway.
Through the chair to Mr. Destin, and this is probably a question for Lisa. Where are the funds kept, and can you borrow from this fund? I know the county keeps it separate, reserves for the,
Well, let me ask this, and because that's a good point, because there are going to be questions that come up that are beyond the presenter's scope of opportunity. If, I believe that might be a fiscal officer question, so Mr. Kennedy, if you would write that down, and when you come up to present, respond to Ms. Conwell's question, that way we won't have to call you up sporadically during the presentation.
Yeah, I can shed at least some light on that. We do know that it's housed, your healthcare funds are housed in a separate fund. It's called the Hospitalization and Self-Insurance Fund. I believe in January of this year or thereabouts, the regionalization funds were actually separated out and are held in a separate fund. Beyond that, we don't have any input into where the county houses its funds. We do receive reporting back from the county on an annual basis related to what's in those accounts so that we can then back check and verify our information according to yours.
Okay, hold on. Any other questions on so one of the key roles and responsibilities is to assess, this is the premium that the county, make a recommendation as to the premiums that should be charged for county health, vision, and dental plans?
Correct. Okay. Ultimately, those recommendations are fed through the benefits department and then up to the county executive, and the county executive has final authority on making those benefit decisions based on our recommendations typically.
Okay, Mr. Sharon.
Mr. Dustin, do you also make recommendations as far as what the program should look like, not just the rates?
Yes, sir.
Okay, so the structure and how it functions and how it's contemporary with other plans and programs are part of your recommendation?
That is correct.
And are we looking at, or have you made a recommendation for an HSA?
Yes.
At this point in time?
The county actually had an HSA for approximately 3 years. There was no participation in the program, so we shut it down. But we typically do look at adding alternate plans on a regular basis. And in fact, the county has an HSA platform on its regionalization program.
But for a program with this many lives to have a failure of an HSA, would you consider that to be successful as far as in your past with all, you showed us lists and lists and lists of customers, clients. It's hard for me to believe that you have that kind of failure rate of those programs if they had HSAs in any of those.
I would say the county's participation in the HSA was dismal and was not a success.
Is that part of your responsibility to make sure that that gets employed and utilized correctly by educating how an HSA should work within a program?
Yeah, and I believe we've done that. I think the issue really was one of the county's benefit structures and the way that the rates are set in terms of employee contributions made it very difficult for employees to want to choose the HSA when they have a free plan in Metro Health Select.
But that doesn't make up 100% of our selection process. Makes up a high percentage, but we still have plenty of people that use other plans. So those are the ones that would be most affected by an HSA.
Agreed.
And of those, have you done a cost benefit analysis that would be beneficial to the county for purposes of this recommendation for an HSA as to those groups out there?
Yes, we've looked at HSAs, I think, probably 3 or 4 times over the last several years, and the county executive at that point in time chose not to add any additional benefits to the plan menu. However, because we added it to the regionalization menu, the county can adopt that at any point in time for its own plans.
Okay, and if part of your obligation as the consultant on our account is to also help move and bring forth our plan into 20th century? Is
Correct.
that, am I over exaggerating? I mean, because it's really pretty pathetic that we don't have a better utilization for an HSA program in this county because could be their money that they're salting away and putting forth not only for today but for upon retirement that those HSA dollars follow them. So.
Yeah, I think we are big proponents of HSAs. I think it's difficult in this structure, but I do think if you look at this county's government and its healthcare plans, it probably runs one of the most cutting-edge healthcare plans for government entities. You have an integrated HRA, which is similar to an HSA, that's tied to wellness. You also have a narrow network model plan in Metro Health Select that is arguably probably one of the lowest cost plans in the state. So in terms of actual unit cost, it's very effective.
But cutting edge I would think would include people taking care of their own health by health decisions, which the HSA, as every model I've ever seen, identifies that as one of the most influential factors of improving people's health and health decisions.
I think it's a good one. I think the key though here is if you've got a free plan, it's very difficult to get people to migrate to that without some type of incentive. The problem with building incentives here is that it's essentially becoming a legacy cost. So once you start giving money into an HSA on behalf of the employer to the employee, it's very difficult to start to take that away.
Yeah, but a free plan, if you're giving consulting advice, is not something I would think that we would be wanting to suggest that that's a good place to be for long-term for the best interests of our 1.3 million taxpayers.
I would prefer not to have a free plan, but that's a union negotiated issue that I have no control over.
Thank you.
All right, so let me, just to summarize just this one point, because there are a lot more points you're going to get on, and if you could just elaborate briefly on the phrase you use here as far as rate setting. So you make recommendations to the administration on how to set the rates for the various plans, as well as recommendations as to what those plans should look like, correct?
That's correct.
So how do you determine, once again, not to get into actuarial tables and census and all, how do you do that, and what's the history been with rate setting and as far as with selecting or recommending plans?
It's actually been very good. I think the formulas that we use are all industry standard, and I've got that later in the presentation. But in terms of the forecasting models, everything that is built for the county would be supported by the rate structures that you use. So when you get to the later part of the presentation, essentially there's two components to the rate. There's what the employees pay on a monthly basis. There's what the county funds into to make the full rate equivalent, essentially. That then funnels up to the budget. The budget is built off of projections that we manage.
But insofar as using an example of $15,000 per employee, just as a number, whether it's factual or not, is irrelevant to the conversation. But if you make a recommendation that the plan should be $15,000 per employee, what's the basis for your determining that or recommending that $15,000 is the right number?
So that's a function of the midpoint formula, and it takes into account your prior history claim costs forecasted into the future against what you're actually budgeting in that current year. The difference or the delta would be what you would charge as an increase either to your budget or you would make plan changes to adjust to that.
Okay, all right, great. Okay. Any questions, Mr. Sharon?
Yeah, just following up on your rate. I'm sorry, could somebody else? Okay. Following up on the rate, your rate calculation is based upon what the county pays and what the individual pays. Is that?
That's correct.
As opposed to what the cost is anticipated of what the charges will be for that individual?
So that factors into it. So when you look at the midpoint calculations and it would tell you, let's say that healthcare is going to cost 10% more next year, you've got to then build a rate formula back that includes plan design changes potentially that might reduce that cost. County budget plays into that, as well as what we want to charge employees. When you work all that back through the formula, it comes up with a rate table. And the county's used those rate tables since 2001.
But isn't that the rate, and you're just dividing the expense amongst those two categories, employee and county?
No, it's much more complicated than that. You've got a rate that's essentially county only. That would be the Metro Health Select Plan, because there's no contributions there. You've got Medical Mutual, you've got United Healthcare also in that equation, along with Caremark. So all of those pieces have to get done separately, and then they're put back together to build the rates out specifically for each plan. So Medical Mutual has its own rate for single and family. So does Metro Health Select, so does United Healthcare, and then the prescription drugs factor in there as well.
I guess I'm having a hard time figuring out the use of the words rate versus cost. It seems to me one is you're forecasting the costs and you're dividing those costs up to create a rate, as opposed to saying that those costs are the rate. It starts with the projection of cost. That's where it starts. And then once we know what the projection of cost is, what benefit changes are going to be made in that given year that may reduce that, we then filter that back to the county budget. The county budget is actually funded based on the rates that you charge your employees and yourselves.
think of yourself as an insurance company. Rather than the insurance company charging you a rate, you're charging an internal rate to yourself that's made up of both employee funds and employer funds.
All of which are based upon an assumption of cost, and the cost increases.
That's correct.
Yeah, we've got to, at least I think we'll come to an agreement, I hope, that everything we're going to charge this quote a rate is based upon an anticipated cost of what it's going to be going forward.
That's correct.
And is there, we have now started to pick up a number of third parties into our plan that came from other existing commercial plans out there. If we were to move a city, a community, whatever it is, into our program, and we would misprice or lower price it in regards to what they were currently paying or what the real claims would be, where would that come back? On us or back on to the losing carrier?
So are you specifically asking the question on regionalization?
We're starting to move to ours because they see an attractive rate.
Well, now we're talking about the regionalization.
Well, we're also talking about how we're picking the rate. We're going back to
Yeah.
the rate structure. We're staying still in the rate structure.
Yeah, so regionalization rates themselves to county or to political subdivisions are all developed by entity. So they're all underwritten. There's guidelines around how it's done, and there's specific protocols that are followed. So everything that is generated ties back to a rate. There's a commitment that's required on behalf of those entities with the exception of the DD board. And they must stay 3 years in order for the county to collect enough reserves to run that program on a fiscally responsible basis, which it is today.
Okay, and then we actually take into consideration when we build those rates, what the historical norms are coming out of any of these communities that we're
Yes,
now
sir.
picking up by
Yes, sir.
what we're doing. So if they've got
We
a series of
actually-
cancer claims, we're picking up those cancer claims exactly the way they are because there's not going to be any pre-existing condition penalties for anybody joining us, I assume, at that point in time.
That's correct.
Yeah, so we're picking up those claims. We're analyzing that. Okay, so that'll be something that we're making our best guess as to what's going to happen, and we as the county are becoming the rate insurance company for purposes of bringing any of those new plans on.
That's correct.
We have no historical background ourselves because they have not been part of our pool.
We look at all the historical background of those entities coming in. In fact, we're probably more stringent than the insurance company when we bring risk in.
Okay, one of the things you talked about was claims experience and forecasting. Is there an aggregate? I mean, there's a claims stop loss for an individual.
Correct.
And then
Yes.
there's an aggregate claims stop loss for our entire program.
There is not.
So we have an unlimited amount of claims cost on the high end, excepting the limit to the individual on an individual claim.
That is correct.
So our aggregate of a whole series of employees, if we had brought in a series of cancer claims or anything of that nature, they are not going to stop at any point as a group at any time.
That's correct.
Okay, thank you.
Okay, Mr. Jones.
Sure.
Good afternoon, Mr. Dustin.
Yes.
Okay. And I think I need a little basic one-on-one. Let me at least share what I think I understand, and then please correct me when I go astray. You manage our health coverage for the self-insured and for our regional service for other cities.
That's correct.
So we have a fund of dollars where when our employees seek health coverage or health benefits, we pay directly without using insurance. We self-insure.
You self-insure, but you use carriers to process claims and to access their discounts.
Okay. And on the regional side, you oversee facilitating the health coverage for smaller cities who find a benefit in using the county.
That's correct.
Fair to say. Okay. My question is, on the self-insured side, we've heard the conversation around what dollar amounts does the county have in its fund. Can you tell us how much money we have right now in the self-insured fund?
I can tell you what we believe you should have. What you actually have would come from fiscal.
Okay.
And I've got a slide for that as well.
Yeah, and Mr. Jones, that's really the impetus that brought us to this discussion today, was to really get a better understanding as to where we are And I know through the rest of this presentation, and Ms. Durkin and Mr. Kennedy, we're gonna get somewhere.
Apologize, I came in late, so I
That's
was
okay.
not sure
That's
if
okay.
it was said or not.
He's writing down your questions, so he'll
Okay.
answer.
Okay.
It's in here.
I would like to just circle back on Councilman Schron's point on the not covering aggregate coverage. County did have aggregate coverage, I think up until probably about 2007, but the program's grown so large that it's a cost you don't need to bear. Aggregate coverage comes into play at 125% of expected claims. That would mean the county would have to miss its budget by roughly $30 million in order to see any benefit whatsoever. The benefit is also very limited because they will cap you at $1 million of loss. So it doesn't become effective to purchase that coverage given your size today.
Okay, if you can go ahead and continue.
Sure. In terms of analysis and reporting, support and backup.
No, I'm sorry, you pick up the second bullet under, we stopped you at the first one, it
Sorry.
rates in.
So ultimately, the county executive has the final say on implementation of decisions. Decisions are implemented for the next plan year by the benefits department with the assistance of our firm. In terms of analysis and reporting, support and backup, as of 2009, the county's benefit department took over the reporting function. They were able to insource that because they had the expertise to do so. So our reporting essentially provides backup to that. It's a separate level of due diligence that we'll be able to tie back on an annual basis. So the county actually sees real-time information on a weekly basis. Our information comes to us from your systems and then is aggregated on a monthly basis. So we track literally everything that happens in the county in terms of a healthcare expense. Questions on that? We use that information as well just to make these projections. In terms of reserve certification coordination, we coordinate with an outside actuary to provide the county with its reserve certifications per the ORC guidelines of 9.833. As of 2014, that was $9.4 million. It was required for the county and the regional programs combined for medical and RX. So that's both programs. And it is retrospective in nature, so keep that in mind.
So if I can, the requirement was 9.4.
Correct, as of the end of 14. We also assist the county in the RFP processes for medical, prescription drugs, dental, which is currently out, along with vision, life, and AD&D. We also do the COBRA, FSA, and HRA programs and the stop loss on an annual basis. The marketing for medical and prescription drugs is done every 3 years. So we are first year of a 3-year cycle for those purposes. So we've locked in our administrative costs along those lines for medical, and then we negotiate the stop loss, which actually goes out in the next week or so. We manage your vendors, so we have lots of interactions with Medical Mutual, United Healthcare on your behalf. The county in particular stops funding of claims at the end of the year. So we've got to manage that process to make sure that the vendors don't get nervous and expect that they'll get paid in the following year. We do provide support for dependent eligibility audits. It's been probably 7 years since we've performed that function with the county, but that's done on an ad hoc basis and as needed. In terms of fiscal and OBM meeting support, we meet with your fiscal folks and folks from OBM to determine what's in the funds. So we've had lots of those meetings recently. We also provide union meetings and education when you go through your contracting cycles. It's our responsibility to provide where the county is going in terms of benefits and then what the expectation levels are from those folks. We handle all the ACA compliance in terms of making sure the county knows what it has to do to be compliant with ACA. We monitor your stop loss programs. Right now, your stop loss is held separately through VOIA. All of your claims funnel up through that, so there is a coordination process that has to happen. When the county has a stop loss breach, those claims have to be filed with the carrier and then the county is reimbursed. So we make sure that all that happens. We also work with the county, the benefits department, and the county executive to set strategic goals and objectives on a 3- and 5-year basis. And then we also look at your SPD and contract review. Any questions on that?
Mr. Germana.
As far as that stop loss, it's not aggregate.
Specific.
In particular to the cities or governmental agencies that are on regionalization, they each have their own stop loss, is that correct?
No, they actually funnel up through the county's stop-loss contract. So the way it works today is that once an entity is approved for entry into the county, they are amended to the county's stop-loss contract. When we price in all of the rating models for a given entity, all of that is factored in. So the key in the regionalization program is essentially to collect more money than you spend. And that's what that process is designed to do.
So that stop loss is by individual because we don't have,
That's correct.
so these smaller entities have got the same benefit of the same stop loss that the county enjoys.
That's correct.
Okay, thank you.
Yep.
Mr. Miller?
To Mr. Dustin, what is SPD?
Oh, sorry, summary plan description. So in order for the county to pay claims in a self-funded environment, we've got essentially a contract document that defines how all claims are paid. That's a summary plan description.
Please continue.
Thank you. The other things that we do for the county, some of which we've discussed here, we do large-scale ad hoc projects. That would typically be the management of your regionalization program. We built that program out so it has all of the underwriting guidelines that support the delivery of that to make sure that the county runs a fiscally stable program. Our responsibilities in that are to do the underwriting. We set the rates. We recommend those to the benefits department and ultimately to the county executive, and he approves the yes or no whether or not those entities come in. We also provide report monitoring, so we make sure that the program continues to run profitably or so that it doesn't lose money. And then we also provide claim supports for those entities and implementation support and customer reporting. So this is a transparent program. All of the cost structures are disclosed to the entities. They know what they're getting when they join. And that information is shared back with them on either a monthly or a quarterly basis, depending on their size.
Let me interrupt, and if I can, just on a bullet, here's the EBI responsibilities on this slide. The double caret there where it says benefits department and the county executive hold final approval. Over the past few years, what's been the history, as far as EBI's recommendations to the county, both on rate setting and on benefit setting?
Not sure. I
Meaning
understand
over the
the question.
years, what have you made recommendations to the county, and if so, what have they been, and what is the action or result of the?
Yeah, so every entity is underwritten. Depending on their size, they're underwritten a little bit differently. Once we are either comfortable or uncomfortable with the risk, we will put together a risk memo for benefits, and I believe that ultimately goes to the county executive for his review. In that memo, we define what we think the risks are, if there are any. If they're too great, we recommend that the county not offer coverage. We have done that several times. And the county executive either says yes or no ultimately.
This is on the regionalization partners?
Correct.
But as far as the county's plan is concerned, so in relation to that as well.
In other words, do we make recommendations and how often are they accepted?
Right. Or how often do you make recommendations, and what's the history been of those recommendations?
We make recommendations on an annual basis. A lot of it is dependent on how the county is performing. But generally, we set out a 3-year plan that ties to your budget cycle. So in other words, for this last budget cycle, 2014 to 2017, we made a series of recommendations. They were not acted upon by the prior administration, so.
Did you at the same time make recommendations on benefit setting, modifying the plans? Was there a recommendation to modify the plans, or was it just merely on the rate setting?
It would be on the benefit setting. So there have not been benefit changes for the county's plan since 2012.
Okay. Mr. Schron, did you have a question?
Then, if I understood you correctly, you make recommendations as far as the regional claims that we want to bring into our risk pool?
That's
So
correct.
a community that wants to join us, you go out and do the analysis and recommend. Now, is your commission based upon total compensation of all claims processed through, or how does that work?
I mean, you're asking us how we get paid?
Yeah, how do you get paid?
We don't take commission, so the county, everything is completely separate. So we're paid by the county to do the consulting work for the county. We're paid directly by each entity, a flat PEPM fee of $8 that the county approves. So the county actually sets our compensation to those entities, and that's billed separately. So the county doesn't bear the cost of that. That was structured by the county that way when we set this program up.
So more lives, how does that, the county doesn't pick up the cost of the additional lives?
In terms of our fees? Yeah. No, it does not.
And then how does that get processed through if it doesn't get processed through in that rate structure at some point along the way?
So it's a separate fee that's charged to those entities directly. So in other words, the county has its rate and it charges its rate, and then there's a contract between my firm and those entities that's direct. So that fee never hits the county.
Okay, so a new community coming in, you build it into their rate structure.
We do not build it in the rate structures, they pay it separately. And the county structured it that way on purpose. Because our fees are capped by the county on an annual basis. We get paid a consulting fee. If you add more lives into that equation, it would essentially inflate our contract based on the lives increases. So our fees for regionalization to those entities do not affect the county, rate structures or otherwise.
Communities will pay based on the lives, essentially.
Correct.
Whatever lives they bring, they're paying your fee.
Yeah, it's an $8 PEPM fee. It was set in 2010. It hasn't changed. And the county's the one that sets that rate.
So, but indirectly, you get paid more by more coming into the county, if that.
That is correct, yes.
Okay, I just want to make, if I'm trying to follow the numbers until I got to where I thought they were. So if 1,000 new lives come in to the county plan, whether or not the county plan is good for the county or not good for the county, ultimately, it will affect your rate structure, your income,
Compensation
your
structure,
compensation.
yes.
Yeah,
That's
thank
correct.
you. Okay.
Other questions?
Please, no, continue.
So in terms of the county's responsibility in regionalization, it's responsible for billing the entities and the premium collection. They also manage the eligibility function. So all of the regionalized entities are entered into your SAP system, and they are managed from that perspective. And then contract management. So each entity signs a contract with the county. They're all fairly standard with the exception of DD board. And every 3 years, those entities are re-underwritten, and the county decides whether or not they're going to keep them in the program after 3 years or ask them to leave.
Mr. Chairman,
Mr. Jones.
how many regional partners do you have? Are they strictly cities or are they other entities?
There are other entities. There's 19 entities, and I think there's Land Bank is part of that program, and Red Center. Board of Development. I've got a list too. Board of Developmental Disabilities, but for the most part, they're all public entities.
Just a point of clarity, the $8 you were talking about is per employee per month?
Correct.
Okay, from the city?
Yes.
Okay. Okay. Yeah, Mr. Sherman.
Why would somebody be asked to leave, and how many have been asked to leave regionally at this point?
None have been asked to leave. We did recommend termination to one. It was not taken. Generally, and the one that was asked to leave because they had a $1 million claimant that we didn't want to keep. They ended up going somewhere else.
So they asked, you suggest they leave, they left on their own accord, is what?
Correct.
Okay. And do they take a piece of those reserves that are in that $9 million with them to the new carrier?
They do not.
Okay, so whatever reserves were built up on behalf of their having to be in the contract for 3 years. So if they wanted to go out and self-insure, they were going out naked at that point in time.
That's correct.
Thank you.
Just to be clear, the entity that was you made a recommendation to remove them from the plan. The recommendation was denied, but ultimately they left the program anyhow.
The recommendation was denied and modified by the county executive at that time.
Okay, so the recommendation, you made a recommendation for them to leave, to terminate the program. The ultimate decision was no, we'll change their program, but at the end of the day, the entity left on its own anyhow.
Yeah, the county has, just so we're clear, each entity receives an annual increase. They have to stay in the program for 3 years. This allows us to capture enough reserves to manage the program. If they leave any time in the 3 years, they do have to pay their own claims and their own run out, so we're protected from that perspective. At the end of that 3-year cycle, the county re-underwrites them again, looks at the risk, looks at what's been accumulated in reserves. If it's positive or negative, we then look at the risk, and if we recommend that they leave, we make that recommendation that we should non-renew them. In this case, we did make that recommendation, but it was modified, and we gave them a 15% increase, and they left.
Okay. All right, continue. And I just want to be mindful of the time, so I know you've got quite a few slides, but we have 2 other presenters as well.
Right. I'm moving as quick as I can. So in terms of Metro Health Select, this is the other major one that we integrate with the county on. We architected the program in 2004, actually, with Kaiser. That's where it started. We are active and just completed negotiations for the new direct contract between Metro Health Hospital and the county for healthcare purposes. We also manage various aspects of this program on a daily basis. The other thing that we were asked to do by the county was monitoring your 457 plans. These are the retirement programs that your employees join on an individual basis. We were asked to provide oversight in 2009. This was primarily due to the criminal investigation at the time of the commissioner system, and we stepped into that role. So all we do there is we monitor the investment performance. We make sure that the county is compliant from its offering standpoint, and making sure that from a fiduciary aspect, the county's operating in compliance with all the laws. So just to give you a basis of the self-funded overview and the historical of it, in 2005, the county moved to a fully self-insured arrangement, the auspices of which was a 61% increase for Medical Mutual. So there are really 3 cost components that we deal with here. One is the administrative costs. That's the network rental fees that we pay to Medical Mutual and United Healthcare, all the customer service that we buy from them, claims processing, and other fees, typically like our fees, et cetera, would be in that coverage as well. Insurance costs. The county does provide specific stop-loss coverage at a level of $300,000 per individual. That means the first $300,000 of the claim is picked up by the county and the plan, and then it's reinsured out to Voya in this case and paid for the balance of the year at no cost. So again, I think what's critical here to know is that we file those claims once they hit, and then the county seeks reimbursement from Voya directly. And we act as the intermediary to make sure that that all happens correctly. Then we also have claims costs. And we do market the stop loss on an annual basis. So that's pure risk coverage that gets pushed out monthly. The administrative costs are on a 3-year cycle. Claims costs, this is the majority of what you spend for medical and pharmacy claims. They're paid in accordance again with that SPE, the summary plan description. And these costs are actually paid weekly, either by wire transfer or ACH transfer. So the other critical component here is the county maintains its own eligibility. This is done through your SAP system. The IT department actually oversees that, make sure that carriers are fed on a monthly basis. It's an extremely important function. This is probably one of the most important functions that the county fills here. And it means that we make sure that we're paying claims on the right people at the right time. Then,
Let me just say, so the last sentence you have, the system reports should be audited monthly.
correct.
Are you involved in that, or is the county involved in that audit function?
We do not interact with your SAP systems. We do audit from time to time as a function of the questions we've received over the last month. We've started to look more closely at the IT function, and we believe there's areas for improvement there.
What is that? I'll let you drink before I. What is that? What does that mean that there? Basically, what the county does, they submit a file to the carrier saying, we have 3,000 employees in your plan. Here's a list of 3,000 employees, or 3,000 lives, so they know who to pay, who's eligible for benefits.
Correct.
And then when claims come in, it's matched up to make sure that we're paying the carrier for services they're to provide. So when you say there's, I forget the exact word you use, but I didn't get a comfort level there.
I'm not sure.
Are you not sure? Are you saying that the preliminary work you've done, do the files we send over have more names or fewer names?
So I would say that the functions worked pretty well up until about January, but we are starting to see some definite patterns since January where county files have more records on them than they're supposed to have. This, again, feeds into our reporting system, so it begs the questions of why are we seeing it? We're always going to have some in terms of when employees are terminated and when they're added. But we have seen in some instances where there are many more records than there are supposed to be.
So does that mean that we're paying those carriers more in premiums?
Potentially, that is one issue. The bigger concern would be, are we paying claims on those people? Because typically if your systems are misaligned, let's say, on the administrative side, you would be paying a monthly administration fee that's credited back in the following month when the file gets corrected. The bigger question, the harder question is, if we paid claims on people, would they then be recoverable from that system? The answer is yes. It's just a much longer process.
You mean if I don't hope we don't employ name Jane Doe, but if Jane Doe is on the list that we send over to Medical Mutual, because she's been an employee of the company for 10 years and she's no longer an employee, but the record still says Jane Doe is eligible for health care. Two things. Number one, are we paying the premium to Medical Mutual for an employee that is no longer employed with the county?
It's
one
possible.
Issue. And
Yes.
the other possibility is Jane Doe could still be filing claims.
That's
which
the other possibility, yes.
Okay.
We don't believe that is happening to any great effect, but we have recommended that the county go through a full claims audit, which is good due diligence for any plan.
And when did you make that recommendation?
We recommended it 4 years ago, 3 years ago, 3 or 4 years ago.
And then do you know if that audit has taken place?
I know to date it has not taken place, but I do know that your internal audit functions are working towards that goal today.
So 4 years ago, you made a recommendation, and the recommendation was not adhered to, which may result in the fact of misalignment in benefits coverage and payments.
I would,
As a general statement.
as a general statement, yes, that's possible.
Mr. Germana?
Mr. Chairman, just to have clarification, because in that case of Jane Doe, we're not paying premiums to the company. We would be paying costs, the claims. So we don't pay premiums, we pay costs.
Okay.
I just want to clarify
No,
that because
thank you.
Yeah,
it's
that is
confusing.
correct. And at least in terms of the looks that we've started to perform as we've gone through this process, we're not sure. We don't think it's a widespread problem, but clearly in terms of the audit function, there needs to be some tightening of that process.
Okay. Go ahead. Please continue.
Sure. In terms of getting back to the funding rates, the county builds the funding rates. So this was done and given to us some time ago when we came on, but these are internal premium rates. It's for single and for family, coverage plan, biomedical, and pharmacy. These rates are then combined, and it takes into account the monthly employee contributions and the employer funding side of the contribution. As I said, the county benefits department handled this function until 2010. You'll see more clearly when I show you the financial side of it what the concern was, but there was some concern at that time that the county was building up excess reserves and that it needed to draw down on some of those funds. So we restructured how the county started to look at its pricing. So the other component of the healthcare plan is
Let me just remind you, I'm just watching the time. I believe this room has to be used at 3 o'clock, correct? Yeah, so.
I'm moving
I know.
quickly. So reserves. Reserves are used to make sure that the plan operates in a fiscally responsible manner. Essentially, what these reserves are used for is to cover the run-out costs of the plan. So if the county stops the healthcare plan, there will be a liability as you leave, and that liability will be covered by the reserves of the plan. Now, to the question of how do we build the funding mechanisms, let me be clear, reserves are there to be fluid. They are going to increase and decrease depending on the year that the county has in terms of claims performance. What we want is to know specifically what the county has in reserves at any given time to make sure that that matches with the information that we have. If there is a reduction in those reserves, we will add that back into the formula for the following year so that we can, in theory, project and recapture those reserves to make sure that the plan is fully solvent. The reverse is also true. So in good years where the county makes or doesn't make more money but has more money available, we would then use that as a credit in the formula to pull those reserves down to a level that makes sense. As I said before, all of this is governed by ORC, and this is guidance only. There is no set requirement. I want to be very clear on that point. Guidance is given by 9833 in the ORC, and as of the end of 2014, that certification amount was $9.4 million, and that was combined for both regionalization and the county itself. You can choose to carry more or less, and the county has carried far more than 9.4 million to our knowledge, and it's entirely up to the county. It does need to be concerned that you don't carry too much because you are also using employee funds, so it's important to run a healthy plan that allows you, if you have a bad year, to sustain that without having to make major changes unless you choose to, but that's what those reserves are for.
Mr. Chairman?
Mr. Miller and Ms. Conwell.
At the end of 2014, what was the amount that, according to your records, we should actually have had in that reserve?
According to our records or according to county records?
Both, if you know.
I'll address what we know in a future slide, if you'll allow me to, in terms of what the county had in reserves. We estimate, well, we saw OBM reports, and this is regionalization and county combined, also combined with DD Board's guarantee of 1.75 million, so give or take about 26 million in reserves at the end of 2014.
How does that separate
Well-
between regional and?
So that was about 13.5 million for the county, about 10 million for regionalization, and 1.75 million for DD Board.
Ms. Conwell.
Through the chair to Mr. Dustin, you stated that you need to know about the reserves. How often are you inquiring to keep up with the reserve amount?
We certainly inquire annually, but generally we inquire every 6 months.
Okay, is that a document sent over to you, or how's that
Correct.
work?
It comes from your OBM reports.
So you only require annually, but you're looking at it 6 months out.
We're tracking it individually as well. So in our reporting systems, which I'll show you, you'll see that we actually track everything monthly. So we run what we call a running reserve variance for the county. We do it both for the county and regionalization. The key is that our records and your records match up on an annual basis.
Thank you.
Please continue.
Sure. We then use this information, all of it, to then forecast the county's expenses for the upcoming plan year. We use that midpoint formula that I described. Now, where it gets critical is we build the funding models for the county to be a break-even model. The reason we do that is if we understand that you are fully reserved, you do not need to accumulate additional reserves unless we think there is something in the system that would require that. So we are building you to break even. You're going to take in and spend what you have in the budget. And that reserve wouldn't necessarily be touched. So in a bad year, the reserves are going to come down. In a good year, they're going to go up, and we price that into the formula. Okay?
Makes sense.
Questions? And again, that process also takes into account any benefit changes that we would make. So in a year where we're having a difficult year, we would then propose changes in the following year to correct that. That makes sense to everybody. So historical performance. I'm going to give you some basic demographic information just so you can get some sense of the scale, and then we'll talk about what we see in the system. So this is a slide that shows the average subscriber counts and membership counts from 2010 to 2014. Subscribers would be the number of employees covered. Members would be the total bodies covered, and this is a combination of county and regionalization combined. So you can see that the program has grown over really since 2012. There was obviously some changes scaling down of the county in 2010 and 11. This is the demographics by carrier. MHS is Metro Health Select. This really is designed to show you the growth of the Metro plan. This is important. So the county operates Metro Health Select. This is a narrow network model plan. Yes, sir.
I'm sorry, back to the previous slide, just a point I want to understand. Between 11 and 12, the number of members, so the number of lives covered, stayed relatively the same. However, the number of subscribers was down. So because the county participates at 100% with the Metro plan, or even the others were at 90-10, because we participated a certain amount, and for a family it's still fixed, whether it's 3 or 4 or 10, right? Mm-hmm. So we obviously then, on an average subscriber to member ratio, went up.
Correct.
Which means our exposure, financial exposure, would have gone up because we had more members but less subscribers.
Correct.
So our revenue went down, but our potential for exposure increased.
Yeah, and some of that it could have been deletions, or, the county was going through a period of time where it was reducing in size. It could also be that was also around the time when ACA was really getting started, so we saw more people coming onto the plan. There are a number of factors that could.
I mean, even if you go into 12 to 13, 13 to 14, so 12 we had 6,200 subscribers and 6,900. So we had basically an increase of 700 subscribers, but we increased by the number of members by 1,500.
Well, some of that is regionalization, so this is a combined slide.
All right. Okay. All right.
Okay.
I didn't mean to interrupt. I just want.
That's
Cool. Staying on that slide, the purple is the regionalization piece?
no, that's.
No, on the slide before that you were just working off of. There you go.
There we go. Sorry about that.
Right.
No, that is just the membership count. So that's the number of covered employees by the plan and the number of members that are covered. This is regionalization and the county combined.
Okay, where does the county stand alone on any of those slides, on either of those bars?
I don't, but I can certainly pull that as a follow-up. We have that slide. I just didn't include it.
Yeah, I'm curious because it, obviously on the average members from 12 to 14, it grew 20%.
We actually have that in tomorrow's presentation, so I'll make sure you get a copy of that.
Yeah, I'd like to see the breakdown of how
Yes.
that shakes out.
So again, this is the demographics by carrier. If you look at MHS, which is Metro Health Select, MMO is Medical Mutual, UHC is United Healthcare, and HealthSpan was the old Kaiser. You can see that in terms of HealthSpan, that over a series of years, HealthSpan grew smaller, and Metro Health Select grew much larger. And it is one of the reasons that the county has maintained the cost structure that it has. This is critical to understand for a couple of reasons. Metro Health Select is a low unit cost plan. It's also a low risk plan for the county because we narrow where people can go, and they're a low cost facility. I don't have to worry about large portions of our population migrating to higher cost facilities. So if you think of it in terms of the risk component, the more people that migrate there, the more control we have over that cost structure because we actually set it within the county and Metro together. However, the downside of that is we are now at roughly 2,700 employees in that plan. We don't view that plan as having much more growth to it. We think it could have some small growth, but we don't expect that we're going to get any more what I would call cost leverage out of it because it is in a mature state at this point. Okay? So you asked before in terms
Can I
of,
ask one more question on that previous slide? Do we have any sense as to why there's so many more in medical mutual than in UHC?
yes, we do. So the county runs what we call a pay for performance model. It rewards lower unit cost providers with lower contributions. United Healthcare is the most expensive plan, therefore it has the highest contributions, and hopefully that then drives people into choosing lower cost plans. So this will give you the medical per employee per year costs from 2012 through 2014, along with a 3-year average. It benchmarks the county against the SERB report in the state of Ohio, all Ohio counties, the Cleveland region, and all employer groups greater than 1,000 employees and national. You are the red line. You can see, I think, just in terms of the unit cost structure, the county has one of the lowest unit cost structures in the state, candidly, given the relativity of the benefits. The one thing you have to be concerned with in the SERB report is that once you get south of Columbus, the use of high deductible health plans, both HRA and HSA, are heavily in those counties down there. So, it does tend to skew some of the data. But I think the bigger component that I would have you focus on is the fact that the county's had relatively stable cost structures in a period of very high inflation. The 2013 was when the benefits were changed. So that was the first major restructuring of the benefit program, and that's why we received that lower cost.
And just what do we, I don't want to say charge, what's the appropriation per employee?
In terms of, I guess I don't understand the question.
So if we contribute, say with the Metro Health Plan, we pay 100% of the premium, what's that cost?
I don't specifically have that broken out in these slides. This is a blending of all plans because we don't know necessarily where people go, but it is still the county's lowest cost plan, even with the cost share. On average, employees, depending on where they go and the blending, employees pick up roughly about 5% of the total cost of the healthcare plan.
And what's the total amount we budget? We budget 75 million or so. How many employees?
2014, it was about 75 million.
And so I'm trying to get, what's the average? These are costs, correct?
There is no pullout of employee contribution. This is just gross cost. It's not net.
Right. So maybe I'm reading this wrong. As I understand, this is what we pay out average per employee over the course of a year.
Correct.
So what's the top line budget associated with that? Meaning, let's say it's $12,113.14 is our outflow. Mm-hmm. What's our inflow into the plan?
Should be, if we hit our targets, it should be the same.
Right, should be, but what I guess what I'm getting at, what is it? You made a recommendation a number of times for increasing.
If you'll give me one or two more slides, I think I can probably answer that question in detail.
Okay. Mr. Schron.
How many of those, where we're trying to compare apples to apples there, have a Metro General as a component where it's fully paid by a county? Do you think on what you're showing us here? So
is your question how many
have a local community hospital whereby in their program they're picking up 100%? Because a third, what you showed on the previous slide, is that almost a third of our employees, or a third of the group, are using the Metro program.
It's actually about 44%.
Okay, well, I gave a Kentucky winded.
Solid though. Yeah. I would say from our knowledge of the state, the county is the only entity that actually has a direct contract that we know of with its local hospital. So the second part of your question would be, how many entities provide a free plan. I don't have the specific statistic on that, but there are very few.
Okay, so that's driving this slide more than likely, the activity or the action of employees to also use that.
No question.
That program. Okay.
Yes.
Thank you.
Let's do this, just once again, if you think you can maybe wrap up in 10 minutes?
15 for sure.
Okay, and let's ask my colleagues at this point, let's reserve our questions till the end of his presentation.
So just real quick, this is just to kind of give you some sense of the scale. The reason that Metro Health Select exists was for the county to be able to get a handle on what it gave Metro Health in terms of both its subsidy and the funding that it gets through employees and their claim costs. You can see the red line there has been steady growth of that as well. Your questions in terms of what we think is in the plan, and I think this is the critical slide. So we went back to 2004 since inception. We took all of the funding rates that the county uses internally, and this is county information, and we built out the rate structures by plan. So we took the number of employees, the number of singles, number of families, we multiplied it out by the contract counts in the given year, and that gave us the funding income rates that you see in that second column. The expense, and this is broken down by self-funded, fully insured, and then total. The expense associated with that would be the plan expenses out of the plan. Critical thing to understand here is this: the county stops funding well before the plan year stops. So there is carryover. In other words, claims stop getting paid sometime potentially in November. Those claims then get held and then pushed into the following plan year. Our systems, our reporting systems, are designed to pull that information back into the period in which it was incurred so that we can understand what the actual cost structure is. So we've done all of that for you, and then we've built what you see is the reserve build in year one through the end of July of 2015. So this is using your funding rates all the way up until 2010, and then our projected funding rates through 2010 up to today. You can see, if you look at the bottom line, in the reserve column, that our estimates would tell us that the county itself, not regionalization, should have just over $12 million in reserve as of the end of July. This is well funded and well in excess of what you need to terminate the plan. And this is your information. The other column, the fully insured column, shows the fully insured costs as they came down and dwindled away. And then you see your total costs over that series of years. And you can see through 7/15, we are having a rough year. And there are reasons for that, which I will describe. So
We're going to hold questions.
got it. Okay, perfect. So again, 2015, why are the county's expenses? Well, they're generally predictable, and we think we can predict them generally within 1% to 2% in a given year, assuming we have all of the information that we need to make the projection. You are going to have good and bad claim years. That's just a fact of life. 2015 is proving to be a challenging year, primarily because of pharmacy costs. To give you some sense of it, we did a deep dive into the pharmacy components, and we've seen that they've increased significantly. We looked at the period of 1/14 through 8/14 against 1/15 through 8/15, and these numbers are staggering. Your specialty costs are up 381% from $633,000 and change in 2014 to just over $3 million in 2015. We've seen the number of specialty utilizers increase by 79%. That went from 42 in 14, that should be 2014, sorry about that, to 75 in 2015. Your compound utilization is up significantly. Compound utilization is when you take an existing medication in a delivery form and you change the delivery form. Think of it in terms of a pain medication. I take a $300 pain medication. because the person can't take it, say, orally. They will compound it through a pharmacy, and it will turn that $300 medication into a $35,000 medication because of the delivery system that it operates in. We've seen your therapeutic class shift. So Hep C, which I think some of you have heard a great deal about, the increase in utilization is 467%. We have today currently, I believe, 14 utilizers on the plan, and it is significant in terms of cost. This is a cure. The reason it's important to understand why this exists is most Hep C claims in the past would have never hit the county's plan, simply because most people that have Hep C walk around with Hep C their entire lives and have very little claims tied to it. It's only later in life that they typically start to see liver transplants, blood transfusions, etc. Now that there is a cure, those people are actually seeking that treatment, and that treatment can range anywhere from $150,000 to $200,000 depending on the delivery site. Let's see, in terms of the additional specialty drugs are immunomodulatory agents. These are high-cost cancer drugs. We've seen those increase by 24%. And then in terms of your top 10 ranked drugs, in 2014, those accounted for $1.3 million in spend. Now in 2015, they account for just over $4.2 million in spend. That is the sum total of why today the plan is running in the negative. However, this is not that big of a deal. It's manageable. We've put protocols in place, specifically around the compound pharmacies. Those took effect in July. We think that that will probably subside or go away. The balance of the changes we've proposed to the county executive should have some impact to that cost structure, but I can't change the number of people that are going to seek these treatments. They are going to go up, and it is going to get more expensive. It's that simple. Questions on that? The other reasons we'll see cost increases, the Metro Health reimbursements will increase because of the new contract that was recently signed. However, it's important to note that we've locked those costs in terms of our percentage reimbursements until the end of 2017. So we've actually probably mitigated some of our inflationary risk in that equation, but there will be some adjustment in the cost structure in the short term. The other issue is that benefits have not changed since 2012. That is a very long time to go without making changes to benefits. Inflation has taken over. Inflation here in Northeast Ohio for healthcare is about 6.5%. When you combine medical and pharmacy is actually escalating to about 22, 23% because of the specialty spend. And then the changes that we proposed were not enacted by the prior administration. Questions on? I'm waiting. Again, as I said, new pharmacy protocols have been put in place to mitigate some of the cost increases. We do believe that the Hep C costs will subside. They're not going to go away completely. When we look at the situation, roughly half of that population is midway through their treatment. So we do expect that they will complete their treatment over the next couple of months, and then those people will be done and out of the system. This is not a medication that you can take more than once. Okay? But we do see other costs increasing. Just as an FYI, we have a very high population of folks with cystic fibrosis and hemophilia here, and those are very, very expensive medications. And there are new medications coming on the market that are even more expensive. So we don't see that this is going to abate anytime soon. We have made, or we have proposed changes, and we are looking at potential modifications to those changes as well. We've proposed those to the county executive, and they're reviewing those things today. We do expect that if we do make changes, that we will keep within our budgetary requirements through 2017. This is a very manageable problem, but it does need to be managed. So 2 more slides, and then I think we're done. Just in terms of the regionalization program, again, ORC is the auspices for the regionalization program. It was started in 2010. Everybody receives a community rated increase based on the entire program's experience and the county's performance. The county is essentially the base rate or the community rate of this platform. So everyone is rated separately when they come in, so every entity has different rates, and they're given the same percentage increase within that annual cycle and they're then reviewed every 3 years to make sure that they're priced appropriately. If they need to be re-rated, we'll re-rate them. And if they need to be dismissed, we would dismiss them or make that recommendation. In terms of the claim liability, the county does take on the claim liability in exchange for a fully insured equivalent premium. These premiums are developed by our firm and they're implemented and managed through the county. They fall under the county stop loss contract, and the county charges an administrative overhead fee to cover its expenses of operation. This would cover the benefit department costs to be in the program. The county determines what that is on an annual basis. We have input into that process, but they can adjust that fee on an annual basis. And again, there is a multi-year commitment in terms of those entities. They have to stay in 3 years. They have penalties if they choose to leave early, but they can. And this allows the county to build and maintain a pool of reserves, which runs that entire program. So we did essentially the same thing in terms of the reserve requirement, because there's been some questions around that as well. Again, we use a 3-year reserving strategy, so that is critical to understand. New groups coming in, we generate those reserves that we need to fund those claims over that subsequent 3-year period. So we do have some short-term risk in this process, but we can manage that on an annual basis. And you should also know that this program is not unique. There are many other programs like this in the state of Ohio. We manage 2 other ones, and most of those have been in plus for more than 10 years. They all run not profitably, but they all run fiscally responsibly, and so does this one. When we did the same review, you can see the number of entities that have joined since 2011 and the number of contract counts that it covers. A big chunk of this is DD Board. So DD Board has about 850 employees. They are treated differently. They are treated on a break-even basis annually. So they can leave or stay in the county's program at their choosing on an annual basis. They actually guarantee their reserves separately. So you have a contract with DD Board that states that they have to maintain $1.75 million in reserves. It's not housed on the county's books, it's contractual. And then there is a reset provision annually. If they spend more, they have to pay it back annually, and vice versa. If the county takes in more, it then pays them back, so it's all cost neutral. So when we value all of that together, taking out DD Board from regionalization, regionalization should have just under $2.8 million in reserves, and those reserves should grow. And then the total contractual reserve is about $4.5 million. So when you capture both of those 2 pieces parts, the county and regionalization, you're looking at roughly almost 17 million, 16.57 in reserves. That's what we calculate that to be. So to I think Councilman Miller's question before, or was it your mine? I'm not sure. At the end of 2014, we saw an OBM report that would indicate that there was roughly almost 14 million in reserve for the county, 10 million in reserve for regionalization, and 1.75 million for the DD Board on their funding. So they don't match.
Okay, and open up to questions. I'm sorry, you hit the thank you. Okay. Any questions? Mr. Schron?
Based on your many years of experience and all the clients you have and working in this area with your expertise, do you think it's in the best interest of an organization to be providing a zero-cost program benefit based on your experience?
No.
Based on your experience, do you think that it's in the best interest of the taxpayers or an entity to be providing something as low as 5%?
That's a tough question. I think it's a relative question. But I do think that the cost should come up.
Thank you.
Any questions? So let me just so I understand the slides 31 and
25.
and 25. So when you say income or premiums on both, I'm assuming they're the same thing.
Correct.
That basically is the number of employees times the stated rate.
So the county has rate tables that
Right.
it uses internally. I think there's roughly 36, 32? 64 rate tables, depending on the groups, the general fund agencies, et cetera. Again, that's what we're given to work with. Those funding rates generate your budget. So when you take all of the singles and families in each plan, based on what the employee pays and what the county pays, that combines to be the internal premium rate. When you put all of those together, it matches your budget, the budget that we help you project.
Okay, and the expenses are accrual adjusted expenses, meaning.
That's correct.
So the county may report something different because they're cash basis, but you adjust yours based on effectively matching revenue, the period in which the revenue was received versus the expenses incurred but maybe not paid in that same period.
That's correct.
Okay. So you're saying and you monitor these because you get, how do you know how do you verify the revenue and the expenses? How do you come up with these numbers?
We pull information off of your systems. We have rights into your claims system, so we're actually able to download this information directly from the carriers on a monthly basis. So you see it in real time on a weekly basis, so there will always be some timing differences. But at the end of the year, everything should foot within a small window of timing. We also pull information from your eligibility reports, which you send us. We then work off of the rate tables that you give us. And we put all of that back together to formulate your budget and your rate structures.
So at the end of the day, and then if there are no other questions, we could have Mr. Erickson come, but at the end of the day, you're saying that our reserves should be higher than what you currently have visibility to?
I would say I don't know.
Okay. So you're showing 16.6 million is what the balance should be as of July 30th.
Correct.
Okay.
And we think that the money is there. We've been doing some research around it, as has the county executive. He's asked us to look into this.
Okay.
Again, I think it's just a matter of where the money is kept.
Okay.
I think the regionalization has more money in it than it's supposed to. That's what it looks like to me, but we've got to get the math to foot.
Okay.
Because I am extremely confident in our numbers.
And you have made a recommendation to modify the rate, is that correct, for the next couple of years?
We have sent a memo saying we would like to hold off on that recommendation until we understand whether or not our numbers and your numbers match. Because if I don't have them matching, I can't make good recommendations.
Okay. All right, Mr. Miller.
The administration made a request for a transfer of $9 million, which actually is what led to this meeting. My question is whether you feel that much is needed, or whether because some of the items probably won't continue at the rate we've seen so far this year, whether a lower number would be sufficient.
So I will state it this way. That request was made essentially based on a straight line version of what you were spending out of the pharmacy program. And I think that's where I think much of the questions lie.
But you did not make that recommendation for the 9 million.
We did not. We were asked to support why it was needed.
Okay. But you didn't come up with it, I guess maybe to Mr. Miller's point on the 9 million, that was.
Well, so I think you need to look at it in the entire context of what we know today versus what we knew a month and a half ago when there was that request. What we see here, and this wouldn't be inclusive of those funds. Right now, I would tell you that you should have $12 million in those accounts as of the end of July. So there would be no request necessarily for additional funds in the pharmacy component. We think that the buckets are misaligned. So if you in fact have the money, I don't know that it's necessary to that point. When that request was made, the bucket itself, the pharmacy bucket didn't have the money. So there was a look at what you were spending on a monthly basis, and it was straight lined across the board to say, this is what we think it'll be, because that's what we're spending today.
Okay.
Does that make sense?
Mr. Miller, was your question answered?
If in our world, I would tell you, globally speaking, the fund against the budget is off by about $3 million through the end of July, which is about 4 or 5%.
Mr. Jones?
So,
Oh, I'm sorry, Mr. Miller.
So, however, if we were to not add additional money, would that likely result in that at the end of 2015 that our reserves would be less than the guidance?
I don't believe so, but I need to confirm the numbers, because if my numbers are correct, it would tell me that you need 16 plus million, or you have 16 plus $1 million between both funds. That is far more than you need. The actuarial certifications in 14 were just under 9.4 million. They will be slightly higher this year because you've got more folks in it, but your reserves based on our information are more than adequate for both plans.
Understood. Thank you.
Mr. Jones?
I know our fiscal officer is just getting his feet wet and getting settled in. Mr. Kennedy but has he weighed in yet? And
We're gonna hear from Ms. Durkin next, then Mr. Kennedy. Yeah.
I know he's probably going to answer this on his own, but he just received this information as well this morning.
Okay.
So we finished this up over the weekend.
Okay, great. All right, any other questions? Thank you for your presentation and information today.
Sure. There we go.
All right. All right, thank you. Ms. Durkin?
Good afternoon. Lisa Durkin from the Department of Human Resources. I believe that the question posed to me today is, what is the responsibility for the benefits programming?
Well, yeah, so let's look at this way, okay, so now we understand the consultant's role in making recommendations on the plan, rate setting, and plan benefits and modifications. So as I understand the role of the county, we take the information from the consultant, it goes through human resources, and then through fiscal. So we want to kind of understand, now I think we've got a pretty good understanding of EBI's role. Now, what we'd like to understand is HR's role in taking that information, what you do with it, and where the recommendations from EBI go once they come into HR. And then to Mr. Miller's point is a little further explanation on the $9 million request, which was really kind of the driving force that brought us here today to get this further explanation of the plan.
Mm-hmm. Certainly. So if I may just begin with EBI, as you just heard, recommends the rates, recommends benefit design, and really the benefits division in HR is the partner and implementer of those rates and the benefits design. So we work with EBI and we get the information from EBI, and we participate with EBI in describing those needs and those potential changes and recommendations to the administration here at the county. Why these rates and potential changes or recommendations are good for the county healthcare program. Based on that, after the executive has agreed with the recommendations or given the information on the progress forward, we take that back to the benefits division inside of human resources, and we set the rates into our human resources information system, SAP. That results in the correct amount of money being deducted from paychecks depending on the manner in which employees have selected their benefits choices during open enrollment. Not only that, but then the benefits division administers the benefits programming as well. We do all of the informational programming to employees. We make sure everybody understands their benefits program. We liaison with the providers, MMO, United Healthcare, Metro Health, Caremark, and we give all customer service to our employees and the regional entity employees. So once those decisions are made, recommendations made by EBI and benefits to the executive gives the decisions, and we implement those decisions. We then do track billing and premium collection on the regional side, as well as the member enrollment on the carrier side for the county. Basically, we then do modeling based off of that, and we look to make sure that our modeling will match with EBI's. That is kind of in a nutshell what we do, but I can answer questions to that.
Okay. Are there any questions? Ms. Conwell?
Through the chair to Ms. Durkin, you stated the executive is given the recommendation, so I think I'm kind of lost here, and I think the chair, EBI does the recommendations, that goes to you, so when you say the executive is given the recommendations, then he rules on it, so once you get it, can you tell us, does it go to fiscal, and then they send it? So that's kind of what I need. Follow it through.
Certainly, to the chair, to the councilwoman. The recommendation, basically EBI and myself and perhaps other members of the benefits division meet with the executive and explain all of the recommendations and, talk through them and assist with arriving at recommendations.
Those recommendations are, generally, if the recommendations are turned down, primarily, they're probably based on a financial component. Would you say that's more of an accurate statement?
I've seen recommendations be successful or not successful for a number of different reasons. It could include financial impact. It also can include impact on our program as a whole. We often struggle with impacting the cost on our employees who have not had a great deal of raise in compensation over the past 10 years as a whole. We are looking to maintain our ability to recruit and use this as a recruitment tool. So there have been a number, or perhaps it doesn't, perhaps it does not remain consistent with other priorities of the administration. So there, I have seen a number of different reasons why benefits recommendations may or may not be successful.
Thank you.
So let me just follow up on that real quick. I know you've only been interim director, well, it's been almost a year since November, but unfortunately you've got the longest tenure of any county employee in this area. You've lost some people over the last couple of years last couple of months who've been helpful in assessing recommendations. Is that correct?
That's correct. We lost our long-term benefits manager last summer. She retired after an illness. We also lost a very crucial member of our benefits team in the rate setting capacity. Not only that, though, we've lost a number of our cohorts in the fiscal office. We had folks who we relied on in the fiscal office to help us administer our finances there, who have retired and moved on, and they were long-term as well.
So the fact that we've got some discrepancies between EBI, between our consultant and our internal folks, there are explanations as to why we very well may have these discrepancies.
Certainly, and they are not difficult to surmise. One thing is, for instance, just the normal movement of dollars from our fully insured index codes to our self-insured. These types of things that might have been done on a more regular basis when we had the staff there that had been doing it for years and years, and now that they're gone, I think just last week we were like, oh, well, that should have been moved. So yes, there are a number of things that definitely need to be made sharper with the folks who are learning how to do this. And it's not to say that we didn't see these exits. Well, for the most part, we knew that the gentleman in the benefits division that dealt with a lot of our fiscal, we knew he was leaving for several months, so we did have folks sit with him. But again, these are complex things that take a little bit more time to learn.
I'm trying to look at the clock and be brief in my questions, and Mr. Schron has a question as well. Over the past few years, we've had, there have been recommendations to raise, and you're not going to know the answer to this, so if you can get back to me with this, to make rate adjustments to the plan. If those adjustments had been accepted, if you can get back to us at a later date, how would that have impacted the plan based on what we know the cash outflows are? Because it would have had number one, have increased the inflow to the plan. It may have had a negative result in our reserves, but I would like to know what that looked like. The other question I want to ask regarding, there was a statement made that on a consistent basis, auditing the SAP data, the data that goes over to the providers, there's been a growing discrepancy. Can you just respond to that?
This is a discrepancy that we have noticed in our shop all year and have been having recurring discussions with the IT group on. Those discussions are going to be revisited at a much higher rate.
So
based on our new
are we saying that
information.
there's no financial, even though we're sending over more data, more participants, are we saying that there's no financial impact to sending over more paid
I'm not
participants?
saying that.
Do we know?
I don't
Or
know
maybe
at
that's
this-
a question for Mr. Kennedy. I'll ask that question of him. And he may not know the answer now, but just a question. The last question I have, and then I'll turn to Mr. Schron, has to do with the $9 million, which really is the kind of the catalyst that brought us here. So there was a request, which we saw in our last council meeting, which we took off the agenda, to fund the RX, the prescription fund, to the tune of $9 million. And it was withdrawn both at your request and at our request. What was the history of getting to the $9 million, and where do we believe that number may be today, if at all?
Thank you. Yes, you and I showed up in the office at the exact same time to withdraw that request. Thank you for pointing that out. I think that the request was made basically from doing, as Jim Dustin said, a straight line analysis in the benefits division that may have been more reflective of how the spending is without fully having the appropriation in the contract. And when I asked for a full accounting of what that $9 million was made of, on its surface it looked fine, and I could examine that and say, okay, I could agree with this. But when looking more in depth, which I had more time to do in the couple of weeks after we made that request, I noticed that there were some things in that straight line that were not meant to be repeated in there at the rate that they were repeated. And I also noticed that the appropriation that was put in the contract in the first place was probably not fully accredited to that contract as it should have been. So going back now, and as I came to the office, I said, we want to withdraw that and we want to go back and give you a good number. I don't believe that I actually feel confident in the number that I even have for you today. Okay. So I'd like to get back to you on that.
And then, I know I said, just a procedural question. When you make the recommendation, how does it ultimately wind up before us? Aren't there other checks and balances along the way? I mean, I candidly feel we shouldn't be the ones checking that and questioning it at that point. It's our role, but it appears to be a big miss. How did that miss get all the way through to be on an agenda?
I don't believe that there is another procedural check.
Okay. All right, Mr. Schwab.
Thank you, Mr. Chairman. Mr. Durkin, how long have you actually been involved with the HR function?
I've been in HR since 2007. I've been involved with the benefits function since 2011.
Okay, so four years in the one and roughly, 8 years on the other?
Correct.
And during that period of time, have you found that how those rates get placed would affect decisions by individuals as far as their selection process within programs and plans that they would select for their own individual coverage?
To the chair, to the councilman, the more expensive the rate, the less participation we do have historically.
So that would affect somebody's individual decision on something like that. So at least if I'm understanding, more expensive, less decisions to go forward, lower.
Historically, for the most part. I will say there are other factors. There are some some of our least healthy population will go with United Healthcare because it'll go on both the University Hospital and Cleveland Clinic Network and the like. So there are some factors such as that.
When EBI comes over, do they give you a rate or do they give you a suggested rate for those costs that are going to drive, broken out by the individual and then the county? Or do they give you one and let us decide, we the county, decide how to allocate that?
To the chair, to the councilman, no, sir, we do get a rate per the employee and the employer.
Okay, so with that length of experience in HR, I'll ask you the same questions then. With your many years in HR, do you think that having a zero rate is a good thing in the best interest of the taxpayers?
How long do we have?
That really is a yes or no on that
Kidding,
one.
no. When I look at the costs for someone who goes to our zero-cost provider for a knee replacement, and I look at the cost for the same person who would go to our non-zero cost provider for a knee replacement, we will pay approximately at least a third to two-thirds more at the other provider. The zero cost is there because while on the premium side, the county will pay more, on the claims side, the county will pay so much less for those same services. And that is where we make it up. So while generally, if I were asked in business, would I ever have a zero cost? Well, no, I'm a good businesswoman, I like to think. But when I look at how the costs come out in the end, premium and what we charge employer and employer, and on Metro Health, what we charge employer is just a small percentage of the claims cost that comes through. The claims cost alone make up for the fact that that is a free plan. The savings in paying that same claim at Metro Health over what it would cost at the other providers makes up for the fact that it's a zero-cost premium to the employees.
So one plan we're subsidizing to the tune of $35 million, and the other one we are not subsidizing at all.
The other,
UH
while it's
and-
true,
UH
we
and
are
Cleveland Clinic.
subsidizing employees to incentivize them into a
No,
plan
the
that
facility,
costs us
the
lower
facility,
on
the facility that you were analogizing. One receives county funds on the other side, and the other one receives no county funds. UH and Cleveland Clinic.
They certainly do. There is an employer portion as well.
I'm not talking about their.
Well,
their-
certainly, I can't speak to that.
Yeah, I'm not talking about the premium piece. I'm talking about the subsidy piece. Okay, thank you.
Okay. Any other? I just have one final question, and I appreciate your patience. So we had a presentation where EBI presented where they believe the reserves to be. What is HR's understanding of what the reserves are right now? As of, hopefully it's July 31, so we're talking the same period.
The reserve statement that I received from the Office of Budget and Management for July 31 was that there was approximately 8 million in the county, and I brought with me today what it was as of Friday instead of what it was as of
That's okay,
July
it's
31.
2 weeks in, I mean, it
Yeah.
should be marginally different. So what is it? So 8 million at the
8
county?
million, and for July 31st, they had for regional, I believe it was 4 million, or it could be 6 million. I have that, and I'll email that to you. This was what we received from OBM regarding the July 31st. This morning, we received from OBM what it was as of Friday's date. That was,
See, because we have here a number of emails from the 21st, there was one number of 8 and 4. On the 24th, there was a number of 6 and 8. Then we got one to last week, which was 6 and another 6 and 8. Maybe that's the same document. And then this one, if it's the same one, is 8 and 11.
correct?
So if we take, although I understand there's some cash timing differences,
Right.
8 and 11 is nearly 20 million. It's 19.7. 19.7 with the qualifier that this is as of the 16.6 is 7/31. This is 8/20,
Correct.
8/31. So a month later. Okay. So, and I also understand there's some timing difference in the regional plan has a run up of about 3 months of premiums before claims are charged against it, but we've stopped accepting premium. We put a halt right now on new participants in the regional
Correct.
plan.
Correct.
Okay. All right. So 16.5, 16.6 and 19.7 with a 30-day variance. in
Correct.
time. Okay. All right. Thank you. Any other questions? All right, Mr. Miller, and then we've got Mr. Kennedy here.
Could you repeat for us what the most recent numbers you have as to what the amounts are in these various funds?
Yeah, the county, what we got today from Ms. Durkin was dated today, there was 8.2 million in the county and around 11.5 in the regional plan.
And would the 1.75 for department for DD be in addition to those numbers?
That, yes, sir, that would be in addition.
Okay.
So we would change that number to 21 and a half. Okay. Okay. Great. Thank you. Thank you, Mr. Miller, for pointing that out. Mr. Kennedy, your time's running out. Sprint. I can't. I appreciate your patience today.
Good afternoon. I don't know how you like me. I know we're
Yeah.
very tight on time.
I apologize.
I can just give you a brief overview
Yeah, please
of
do.
my input into the healthcare plans. As you know, it got confirmed in April, and one of the things that I looked at upon my entry here was really how the hospitalization plan was reported on our financial statements. And in discussions with the state auditors, we did have to change some financial reporting, which will be included in this year's comprehensive annual financial report. Basically, in a nutshell, so everybody knows, it is a pool. We are in a pool. We are responsible for the regional claims. The county has some risk there. So the format in which that was reported was changed. A couple other things that happened once I started looking at how the funds are accounted for is, again, really basics. There's 3 funds that are separate. There's a traditional fund, there's a self-insurance fund, there's a regionalization fund. The natural assumption is you appropriate those contracts to each one of those funds. You coordinate both revenue and expense index codes against those funds, and contracts for the carriers are encumbered against the particular fund. Expenses are paid, revenues that come in are posted. That does not happen. There's 3 separate funds. And I should caveat that to say there's actually a 4th fund. There's a trust and agency fund that is used to wire payments to a carrier. So what happens is checks are cut from one of the 3 funds, or advances made to go to the trust and agency fund, And then what happens is the county then wires money to a carrier, to MMO, to Caremark, to whoever, based on a bill. But there is not a one-for-one corresponding transfer of monies from one fund to another. Now, maybe that had occurred in the past. That is not the case now. So, given that situation, my concerns with the financial reporting, and then the other interest that I had is we were aggressively marketing the regional plan to other communities. I was not confident in discussions with the executive office that anybody was independently corroborating those premiums that were being negotiated and offered to some of the cities. So I had suggested that perhaps we use a group internally to verify that we are pricing that correctly, because once we're in, as I said, we're a pool, we assume that risk. So if that premium is not calculated correctly, or if it's on the low end, the revenue that's coming in is not going to be sufficient in terms of reserves. And while we're talking about reserves, there is no individual reserve for each one of those funds. It's not calculated that way, and it's not recorded that way. It should be, it will be, but it is not right now. We also, up to this point in time, as Mr. Dustin said, from the regional partners, the county gets an administrative fee that's paid per member. That money is commingled in the regionalization money. That should not be considered part of the reserve. It's a separate fee. It's our administrative costs. So when people are talking about numbers that are in those funds, they constitute a couple of different things. They include administrative revenue that should not be calculated towards the reserve. Secondly, when you're looking at the individual fund balances, there's been payments for the regional program made against the county program, which shouldn't have happened, so that skews that balance. There's been revenue postings that have not been consistent amongst the three funds. I had asked for some resources, some help to look into that more deeply. That's what the internal audit department is doing right now. I believe they're 60 to 70% completed with their review. Beyond that, I'd be happy to answer any questions.
Mr. Germana?
So I'm trying to follow this. So depending on which fund, some are lower, some are higher. How far are we off when you come to the total net?
Off of what, compared to what?
Compared to what we're supposed to have?
Well, what I'm trying to do with the assistance of the internal audit department is to independently calculate how much we have. They, in terms of their work, will probably come up with some kind of recommendation or analysis of what it should be in terms of what the responsibilities of the program are. I'm saying right now, because I really turned it over to them at that point, don't have confidence that the numbers that are in those funds are correctly aligned. In total, they may fit fine, but there's other problems. There's logistical problems with moving the monies out of one fund to another to pay out of this trust and agency fund. I'm not comfortable with that from a control standpoint. I don't think we should be paying ourselves money and then wiring the money. We should be conducting the transactions out of the correct fund to begin with. That would have eliminated some of these problems. So we're going to take steps to do that in the future. But we're not really in a position to give you an identification of the accuracy of the numbers in those funds. We have the total amount that's in the bank. I don't know between the three funds and the trust and agency fund what the correct distribution is there. You have to basically reconstruct those payments and revenues and the postings and the way they were posted for a number of years. As you've heard, it's gone back a number of years. That's part of the process. So hopefully when we're completed with that program, we'll get a recommendation as to what actually the balances should be in each fund, and probably some work recommendations related to the elimination of the trust and agency fund.
Okay.
Mr. Miller?
Director, my question is about the report that not all the money that that was appropriated to the health care benefits fund was in fact credited. And my question is, if that's correct, how did that happen? And does that mean that the general fund actually does not have as much money as it was reported in the most recent report?
Councilman Miller, I don't believe that the general fund is at risk for any monies based on how the appropriations were lined up with the funds. It's the transactions that went through the three main funds and then the trust and agency fund to go back. I'm assuming that we will have sufficient reserves in there, but we need to more clearly delineate what those amounts are for each relevant subject.
So are you saying that when we actually credit the full amount to the health care benefits fund, that the general fund reserve balance will actually be somewhat less because of that difference?
I don't believe so at this time. I don't believe it'll impact the general fund reserve, based on what I know right now.
Well, if more money needs to move from the general fund into the healthcare benefits fund, why would that not lower the balance?
Maybe I was not clear. I have not said that we need more money in those funds. I think it's the alignment within those funds, how the transactions are recorded. As I said, that regional claims were paid against the county plan. There's also a question of what the time lag is between how much money is in there on a cash basis. Those numbers that we've heard talked about today are based on a cash basis, but if there's 2 or 3 or 4, in some cases 5 months of pending claims that haven't hit, those balances have an effective balance that's going to be substantially different than the cash balance. I don't have an idea definitively what those numbers are at this point in time.
So are you saying that not all of the original appropriation, it might not all be necessary?
Correct. At this particular point in time, yes.
Okay.
Let me do this. We've got a few minutes and 3 colleagues have questions. So if they can be asked quickly and answered quickly.
I will try.
Mr. Schron.
You indicate the audit is going to hopefully give you what should be? I'm just using your words.
The internal
Yeah, the
audit.
internal audit, yes.
Internal audit.
Yes, sir.
Without the should be, why was there an ask?
Because in my initial review of the funds and how the programs worked, I was not comfortable with the information that was being fed back to me, nor the information on the financial statements. I did not have the resources at my availability to assign it, like on a special project basis. So that's why I asked that group, which is their purpose, to take a
No,
look at.
they asked for the money.
Which for the
The $9 million. Without, you said the audit was going to tell you what should be. Without the should be answer, why did you ask this council to prove $9 million? Why did it come forward?
My understanding is we needed a $9 million appropriation adjustment for the contract. I was told that there was, as we heard some of the history, that because of the pending claims, the Hep C drugs, all those particular cases, that we were going to need that money. I did not want to do anything to prohibit claims from being paid and have a carrier shut us down. But we were appropriating the money, not necessarily making the payments. It was to appropriate the money to have that appropriation available based on what was told to me at that time.
Prior to the internal audit.
Yes.
Thank you.
Okay, Ms.
Prior to them completing, I should say. Huh?
Ms. Conway. It was a mistake.
Mine was just a quick question. How long has the 4th account been established? You talked about the trust and agency fund account that you don't like. How long has that been going back?
It's been 4 years, 4, 5, 6 years perhaps. It's been there a while.
Yeah, we've identified this as not a 2015-ish beginning issue. Mr. Jones.
Just quickly, can you repeat again the actual amount that you know is in the bank?
In the reserves.
In the-
Well, I wouldn't classify them as reserves, but the cash balance as of August 28th, total in the county, what's classified as the county plans right now is a little over 8.2 million. In the regional plan, there's 11.4 million, but that's still subject to verification. Those are cash.
Plus the 1.75 from DD that's committed, if,
Correct.
should it be needed. So those are the same numbers that Ms. Durkin
Correct.
provided. Okay, so,
And those are all kept in one, physically speaking, all kept in one account? Or are they, no, it's maybe.
There's three funds, and then there's a trust and agency fund. They're not necessarily kept in separate accounts. Cash-wise, they're managed by the treasurer's office.
Okay.
all right, great. So let me just summarize real quick. If I understand the projected estimated reserves, HR and fiscal are in agreement, at least on what a reserve should be, and Mr. Dustin, EBI, is at 16.6 versus 21.5, and there's a month timing difference between those numbers.
Yeah, I had not seen any of these numbers today.
Okay.
They were.
No, you'll look, I'm just kind of summarizing what we've
Yeah.
heard today.
Yeah,
We've also heard that the 9 million was a number that was retracted because it's under further review, whether, I don't believe it was a purposeful mistake or submission, but it's under review and it's not believed to be what it is. I think
Correct.
that's a fair statement. This issue, to summarize again, has been going on for multiple years. There have been requests by the administration, by the consultant to make rate changing and benefits plan modifications which have not been, the recommendations were not administered to. Ms. Durkin's going to get a pro forma, or someone from the administration, a pro forma, had those rate making adjustments been implemented, how that would have implemented the plan. So, did I miss anything? No? Zero is not a recommendation, as Mr. Schron says.
May I ask, Chair, so where do we, since the amendment was to take out the 9 millions, when we had this presentation, where are we?
Well, the administration,
At that point.
right now, we pulled it, it's been withdrawn, it's not been held, it's withdrawn. So if there's a request to fund, for this to come back, it's gonna have to go through the biweekly fiscal agenda. But right now, it's withdrawn, it's not being held.
right.
Okay, any other questions? Let me borrow your agenda. Okay, great. Thank you. Well, thank you, Mr. Kennedy. I
Thank you.
appreciate your patience today.
Thank you.
Is there any miscellaneous business before the committee? No. Any other public comment?
No,
unrelated
Mr.
to-
Chair.
Great, then we stand adjourned. Thank you.